Hello friends, so let's watch this PHACOEMULSIFICATION of soft cataract. So I'm starting with the paracentesis at 9 o'clock with my right hand. Now I want to make the second paracentesis now. As you can see, the draping is good, so that starts quite well for me. It's important to have a good draping because the lashes should not get in way and it prevents infection also. So making my second side port with my left hand. Now I'm ready to instill the trypan blue dye. Now, as I'm a beginner surgeon, so struggle of a beginner surgeon here, difficulty in finding the right place of insertion of the cannula. Nevertheless, I succeed and instill the dye into the anterior chamber. Now, it's important for a beginner surgeon to wait for the dye to stain the anterior capsule quite well. So I still wait for it for around 30 seconds at least, and only then wash the dye away. So washing the dye, and it's important to press the posterior lip of the incision while doing it so that you have an exchange of the dye with BSS. Now this is a viscoelastic, which is HPMC, dispersive OVD. Now getting an even fill, a wave of viscoelastic here, coating the epithelium of the cornea as well for better visualization. And now I'm ready for capsular access now. So I typically do my capsular access with a 26G bent needle cystitome, and that is how I've learned. Checking the pressure here, I'm happy with the pressure. Now getting a hold with my limbs, then entering horizontally, then getting the correct orientation, raising a flap around 1 o'clock here, and the flap is raised. Now the capsular access is continued. It's important to have very light friction so that we don't have cortical disturbances. The patient is a myope lady. The IOL power planned is 16 diopters. Now here, as you can see, the capsular access wants to run out. So it's important to understand that the AC shallowed here a bit. So it's advisable to come out of the eye, fill in the visco again, let the AC deepen again, and then proceed with the capsular access. So it is a safety measure, and it's very helpful for a beginner surgeon like me. Now here I zoom in a bit to have more control and better visualization, and now we can proceed with the continuation of the rhexis. And now the rhexis doesn't want to run out because the anterior chamber is deepened with OVD now. Now completed the rhexis here. So is it a very good rhexis? Is it a perfect rhexis? No, not at all, far from it. But is it continuous? Yes, it is. Although the rhexis is quite large, at least 6.5 mm, but it's important that it's continuous. As far as the rhexis is continuous curvilinear, PHACO can be proceeded safely for a beginner surgeon. But an expert surgeon can do PHACO even in a discontinuous rhexis. But for beginners, it's important to have a continuous rhexis. Now I noticed that the eye was very tight. So it's important that while making the main incision, the eye should not be very high on IOP. So I burped out a little visco here. So this is my fixation ring here. A very useful instrument to make the main incision with the eye being in primary position. Now I aim to make a triplanar incision out here around 12 o'clock. Now first plane is made. Now aiming towards the apex of the cornea, getting a good tunnel length, and then entering parallel to the iris. It's important in PHACOEMULSIFICATION main incision that you don't really dimple down, because that makes a chevron, and a chevron incision doesn't seal that well. It's important to have a squared incision. So this incision looks okay. Now I want to proceed with the hydrodissection. It's important that you burp out a little viscoelastic before hydrodissection, otherwise you might have a pressure cooker effect whereby you already have the eye full of visco and then you do hydro, so it can rip the capsule because of high pressure. So I bubbed out a little visco, and then I typically want to go underneath the rhexis, lift the capsule a bit and then do a hydro dissection. And because the rhexis was a little on the larger side here, so we did have the nucleus prolapse. So we should not worry if the nucleus prolapses out here. We can push back the nucleus into the bag. Now filling the visco again and using the wave of the visco to take out the capsulotomy, or rather the rhexis flap. So the hydrodissection has been done, the eye is very tight, and now we should confirm the rotation of the nucleus. It's important for the nucleus to spin to have a safe phacoemulsification surgeon in a beginner's hand. So the nucleus rotates quite well. So now we are ready with the phacoemulsification. So getting a good focus, a good magnification, the centration is quite good, the focus is quite good, I'm happy with it. Now I typically want to go bevel down in position 1, that is irrigation. And tip exposure can be varied according to the surgeon's expertise and need. So in this case I'm happy with the tip exposure that I've got here. Now taking out the superficial cortex a bit, I'm in the sculpt mode, that is the PHACO 1 on my Venturi machine. Making a trench, giving full energy on the forward stroke, then coming back at position 1 and then giving full energy in the forward stroke. So because the nucleus is soft, we already have quite a deep trench out here. The parameters are vacuum of around 100 mm of Hg, the power is around 35%, and the bottle height is around 90 mm, or rather 90 centimeter. Now trying the stop and chop maneuver, and the nucleus cracks quite well because I did see the red glow coming from the center. Now using the foot pedal to go to PHACO 2, that is the segment mode on my Venturi machine. Here the vacuum is 450, the energy is 35, and the bottle height goes to 110 centimeters. And we chopped the first heminucleus into 2 pieces, and now slowly we are emulsifying the nucleus now. It's important to be at the iris plane, and you must be noticing that I'm using the chopper to keep the heminuclei, other heminuclei, to be in the bag. I don't want it to come up right now. I want the superficial nuclear piece to be emulsified first. Then I'm using my chopper to rotate the nucleus, but then I go to irrigation and rotate it with my PHACO probe only, and lifting the nucleus and getting the chop again. So the second heminuclei has been broken into 2 pieces, rather chopped into 2 pieces. Now I don't really need the second instrument because the nucleus is quite soft. So in the iris plane I am emulsifying and giving energy only when the piece is engaged. Otherwise it's primarily vacuum, and then giving energy in pulses once the piece is engaged. So slowly we are emulsifying the nucleus and getting the angle of the PHACO probe towards the piece we want to emulsify, and then bringing it to the center. While holding it, very low vacuum is given. Bring it to the center and give vacuum and low pulses of energy. Now the last piece. During the last piece you can go to epi mode, PHACO 3 mode, and if you are in the segment mode, be cautious with the foot pedal. So now we have already managed the nucleus quite well. All that is left is cortex. So for cortex you have 3 options. One is a bimanual I&A, the other is a coaxial I&A, and some people would prefer even a Simcoe cannula, or rather Simcoe 2-way irrigation and aspiration setup to take out the cortex. Now filling the visco again. So I typically use a coaxial IA handpiece because I have been trained with that only. I don't usually do a bimanual I&A, although in a beginner's hand it is said by experts that one should start with a bimanual I&A, but where I have been trained and I have learned with a coaxial only. So it's important to have the aspiration tip or hole in visualization, and the irrigation ports should be 90 degrees away from it. So taking out the cortex from the 6 o'clock position, giving low vacuum in the low vacuum zone. In the periphery you have to give low vacuum and then hold, get a grip of some cortex and then come towards the center to give more vacuum. So here the vacuum is 500 and the bottle height is 110 centimeter. So slowly we are proceeding, and it's important to have a circumferential approach while taking out the cortex because it gives a good amount of cortex to be aspirated. Now subincisional, very well done. For subincisional becomes a little tricky, but even for subincisional cortex same principle is to be followed. So cortex is almost done, but I do see some remnant on the posterior capsule. So what's that? Let's see that. So it's a remnant of the PSC component of the cataract. The cataract was NS1 with posterior subcapsular component. So what should we do? Yes, we can proceed with IOL implantation and do a YAG laser posterior capsulotomy after say 3 months or so. But I decide to do a PC polish here. So I go to the polish mode where the vacuum is only 20 and I'm just in position 1 with irrigation. I'm using mechanical force to rub onto PC to see whether the remnant material, the residual material dislodges or not. And then I go to higher magnification, focus again, and then start rubbing it with irrigation only. I'm not giving any aspiration as of now, and I'm proceeding with it, and I'm doing multiple strokes of rubbing to see whether it detaches or not. Still the residual material is still there, so I'm thinking of coming out and not trying anymore. But as soon as I decide to do that, luckily for me, yes, the residual material came up, and then I give a little of vacuum to take it out. Now the PC is quite clean, as you can see. So this was the management of a soft cataract with PC polish using stop and chop maneuver. And now zooming out a bit, filling in the visco again. So if you want to implant an IOL, you want to have the AC quite deep. You have to inflate the bag as well. So some people, experts, can do it under hydro also. So whereby they use the irrigation cannula of the bimanual I&A, and they can, under irrigation, they can implant the IOL. But for a beginner surgeon like me, it's important to deepen the AC first. So this is counter traction with the dialer on my left hand. This is a wound assist delivery of an IOL here. So this IOL is Bausch & Lomb Acryos AO, hydrophilic monofocal acrylic acrylic IOL, and it is hydrophilic in nature. It has 4 haptics, and it's a good IOL to start learning about implantation because you don't really have to dial it. You just have to push on the optic near the optic haptic junction, and the IOL goes in the back because the haptics here are quite soft. So the IOL goes in the bag. Now going to the visco removal mode on my PHACO machine. So here the flow increases. In a Venturi machine you cannot actually control the flow, it's a vacuum based machine. So the bottle height increases to 120, the vacuum is still 500. Can you go behind the IOL to take out the viscoelastic? Yes, you can, and it's important in premium IOLs. But for a beginner surgeon like me, you can get away by just aspirating the visco above the IOL. But to take out the visco from behind the IOL, you can tap the nucleus again and again, tap the IOL again and again, move the IOL a bit, and then you can see that the visco comes from behind as well, because the rexus is big here. So we don't really see the famous 360-degree overlap that is preferred for long-term outcome, but nevertheless the IOL goes in the bag. So therefore I said that the rexus is around 6.5, because you can see the rexus margin is not overlapping. The rexus is larger than the IOL optic. The optic is typically 6 mm. So taking out the visco, spending some time here. You don't want to have an IOP spike the next day. So visco, if left sufficiently in the eye can cause secondary glaucoma. So post-op day 1 IOP spike, massive IOP spike. So take your time in taking out the visco. Ideally you should take as much visco as possible. So now I came out in irrigation only. So while entering the eye you should be in position 1 of the foot pedal, while coming out you should also be in position 1. So the IOL is in the bag, the cataract and all management has already been done. So last thing is sealing the wound, and it's important to say it's not done until it's done. It's very important to seal the wounds quite well. You should have a watertight or airtight chamber at the end. So side port, right side port was hydrated here, left side port hydrated. Now coming to the main wound, the lateral walls are hydrated. Some people advise hydrating the roof of the main port as well, but in my hand I don't see it very safe because there are risks of DMD. So I'm happy with this approach of mine for closure. But yes, I don't see a very tight chamber, so I put some air bubbles and then check the pressure again. And yeah, it looks okay to me now. The pressure is still a little less. So if the air bubble is not leaking, so it's airtight, you can get away with it. But I decide to put in a little more BSS and then hydrate the wound a bit. And then I'll check the pressure again. And now the eye is very tight. The pressure is typically around 25, around here, 25 to 30 mm of Hg. So the emulsification has been done, the IA has been done, the IOL has been implanted, and then the ports have been sealed. Now this was subconj, genta and deca combination, that is gentamicin and dexamethasone. And now after you remove the speculum, you should check the pressure again, because there are cases where the speculum was quite tight and when you removed it, the IOL popped up out of the bag and the pressure lowered. So that's it. So this was a case of soft cataract managed with stop and chop technique for phacoemulsification with PC polish. Thank you.